Professor Goel, it is welcome.
Thank you, Dr. Taskala. Thank you, Mehmet. I can see Abdul Rahim, and I can see many other faces, and I'm very happy to be. Okay, so I'm very happy and very honored to present, my lifetime work on Craniovertebral Junction, and I hope you will enjoy this. So I will, Craniovertebral junction is very important for neurosurgeons and for spine surgeons and those who want to do complex spine, because it is highly result oriented. Kind of complex cases, you can give new life. You can absolutely give new life. You can give new neck, and you can give new hands, you can give new legs, and you can give breathing, you can make them work, you can give them new life. On the other hand, if you do not understand craniovertebral junction and you try to operate these cases, you can kill them, you can make them worse, and you can devastate them. So it is important for us to understand craniovertebral junction. It is not easy, it is a complex subject. It is like, this is the pillar, and the pillar bifurcates like this. So to hold the roof, this is bifurcation of the pillar. Similarly, this bifurcation of the two joints, one is atlantoaxial joint and one is occipito-atlantal joint. Occipito-atlantal joint is the most stable joint of the body. Atlantoaxial joint is the most mobile joint of the body, most mobile. Atlantoaxial joint is the most mobile joint and the most unstable joint of the whole spine. So atlantoaxial instability is very common. If I have to say that atlantoaxial instability is the most under-recognized clinical entity in our subject and under-treated. So let me discuss about atlantoaxial instability. So this is the magnificent atlantoaxial joint. You see here, this is the facet of atlas. It is very strong. It is very thick and strong. Next to teeth, this is the strongest bone of the whole spine, C1 facet. See the number of ligaments attachment on the upper part of the atlas. There's too many ligamentous attachment. On the other hand, you see the undersurface of the facet, the lower surface of the facet. There are no ligamentous attachment or attachment seen. So occipito-atlantal joint is the strongest and the most stable joint of the body. Atlantoaxial joint is round and flat. It allows rotatory movements, flexion, extension, and also it allows instability. So instability of the atlantoaxial joint is because there are more movements, there is more instability. More the mobility, more the instability. If you see the spinous process of C2, this is C2 spinous process, is the largest spinous process of the whole spine. Transverse process of the atlas is the largest transverse process of the whole spine. Transverse process of atlas allows rotatory movement. Spinous process, large spinous process allows flexion extension movement. So this is a atypical vertebra. The role of odontoid process in the movement is speculative, and we have written on this. The movements are focused at the facets. The large muscles attached to spinous process move the bone at the facet. Transverse process muscles move the bone at the facets. So all the movements occur at the facets. So facets are important to understand because facetal stabilization is at the fulcrum of all movements. So this technique we described in the year 1987, one screw in C1, one screw in C2, and the facetal movements. So the stabilization is at the facets. So my technique since 1987 involves three important steps: opening of the joint, removal of the cartilage, and putting bone graft inside the joint. So these are the three steps: open the joint, remove the cartilage, put bone graft in the facet joint, and then do atlantoaxial metal screw and plate instrumentation. So this was my first case in the year 1988. You see, it is not occipital fixation, it is atlantoaxial fixation. So as we have progressed, we have over 2,650 cases with such fixation. So C1, C2 fixation. Mobile atlantoaxial instability. Mobile, you see, it is flexion, there is unstable. In extension, it is stable. And there are reactive changes in the spinal cord and atlantoaxial fixation. This is the youngest patient of mine, 7-month-old child. So you can have instability in a child and in an adult. Just a minute, please. The anatomy of this atlantoaxial joint is very critical, and you have to understand this is C2 ganglion. Initially in 1987, I described resection of this ganglion to expose the atlantoaxial joint. C2 ganglion is located right behind the joint. So we had described C2 ganglion resection. But as we have matured in the business of this fixation, we do not resect the ganglion at all times. We mobilize it superiorly and work under the ganglion to do atlantoaxial fixation. Another very important anatomical understanding that one must have is the understanding of the vertebral artery. Vertebral artery as it goes from C6 to C4, C5, C3. In C2, the vertebral artery is the more difficult to understand because there is a medial course of the artery here. And to put screw in the C2 facet, you have to understand the anatomy of the vertebral artery. So we described 9 quadrants, and the medial and upper quadrants are the most suitable to introduce screws like this. The screws, you know, the vertebral artery goes here like this in the facet of C2. So the upper quadrants are the safer quadrants. So you have to put the screw medially and the C2 screw superiorly. So this is one fixation. So there are several cases like this. This is mobile atlantoaxial instability, and there is C1, C2 fixation. We also describe this technique, one screw in C1 like this, and the other screw like Megel's technique. So this we call double insurance screw. So one screw in C1 and one screw like this, like Megel's technique. So this is another case. You see this is post-operative, one screw in C1 and one screw like Megel's technique. So this vertebral artery, which I was saying, traverses from C6 up and then goes medially underneath the facet of C2, underneath the superior facet of C2. So when we insert the screw, this artery can be in danger. And we have to understand this artery. It does not go so much medially always, but this part of the artery is in danger. So you have to understand the anatomy of the artery very nicely before operation, and we use these kind of models you see these kind of models are used to, if the artery is here, the pedicle is so small, so we have to know how the artery is going. So I make these kind of 3D models in complex cases so that we know exactly where to put the C2 screw, where to put the C1 screw. And this is very important to know the vertebral artery location. So I had described these 3-dimensional models for craniovertebral junction surgery. So now very carefully, please see at this C2 vertebra, this is the superior facet of C2, superior facet. And then there is inferior facet of C2. So there, the inferior facet is very much posterior. And they are not in line like the other facets of the rest of the spine. So C2 facet, the superior facet is anterior, inferior facet is posterior, and you have to introduce the screw like this in the superior facet. So when the vertebral artery is in a little bit complex situation, you can use the inferior facet to put the screw. If the superior facet, you are having problem, in rare situation, you can use inferior facet, like I will show you here. See, this is the C1, and instead of superior facet, you can use the inferior facet. The vertebral artery is in relationship to the superior facet. So you can use very effectively the inferior facet like this. Caudally directed inferior facetal screws. So now you see here the vertebral artery is very high riding here. So you may not be able to put the screw here. So what I have done is one screw here and one screw in the inferior facet. So you can use the inferior facet in rare situation. Now this is the case, you see this is the unstable atlantoaxial joint, and you see the C1 screw I have put, but C2 I am not able to put because of the destruction here. So I have used inferior facetal screws. Other thing is, you see as the vertebral artery goes up in the superior facet, you can actually mobilize the vertebral artery to put the screw in rare situation. Now you see this mobilization of vertebral artery. As it goes up like this, you can drill the posterior surface of the facet and mobilize the vertebral artery and then do screw fixation. So mobilization is a new technique that we have described. So this is the case, this is the unstable spine. You see there is a big vertebral artery high riding loop here. So what we have done is we have mobilized the vertebral artery and then introduced the screw. So mobilization of the vertebral artery is a very important technique. You see the very high riding vertebral artery. So you drill the posterior surface and mobilize the vertebral artery like this and then introduce the screw. In some rare situation, possible. In some situations where you are not able to do because of some reason, you can use the spinous process like this. We describe the spinous process and spinolaminar junction and laminar screws. So this article was actually the first where we described screw insertion in the spinous process, in the spinolaminar junction, and in the lamina. So this is the patient, and this was very old. I don't do these things now, but just to show you, I could not put C1 screw. This is very old slide. I could not put C1 screw. I could not put C2 screw. So I used occipital bone and spinous process to hold the occipitocervical implant. In some situations where you are not able to do any kind of fixation, you can do fixation using intrafacetal joint jamming. Open the joint and introduce intra-articular spaces like we had described. So this is also one technique. So like here, there was no possibility of insertion. So I used intrafacetal implants on one side and C1-C2 fixation on the other side. This is rarely sometimes we use. Sometimes in rare situations where you are not able to put C1 screw because you know of assimilation or some high riding basilar invagination. So you can use transcranial insertion. So if this screw you cannot put directly, you do a small craniectomy and then do direct insertion of the screw in the C1. It is possible in rare situation if you are having difficulty. You can imagine I never now put occipital screws, never. Occipitoaxial plates are never used. So these are the complex situations where I have used transcranial insertion and transfacetal C2-3 insertion to do this complex fixation. Now, this is the case I earlier used to do occipito-cervical fixation. So in my current understanding, craniovertebral junction instability means atlantoaxial instability. Occipito-atlantal instability is extremely uncommon. So craniovertebral junction instability means atlantoaxial instability, and occipito-cervical fixation is not necessary. Occipital fixation, according to me, we were the first to describe occipital screws long back in 1987. And I described this kind of construct, occipital C1-C2, but I do not use occipital bone inclusion in any case of craniovertebral junction instability. So occipital fixation, is it necessary? My answer is no, it is not necessary. Now I will show you various kinds of instability. You see in extension, there is no instability. In flexion, the whole thing goes inside and you see the huge fixation, the whole spine is fixed. So we called it vertical, mobile, and reducible atlantoaxial dislocation. Now you know the whole world of craniovertebral junction changed with the concept that there is nothing like fixed atlantoaxial instability. Earlier, you know, those who are senior in the audience will know that atlantoaxial dislocation was called fixed or mobile. So we introduced this concept that there is nothing like fixed atlantoaxial instability, and you can reduce atlantoaxial instability. Those who are in this business of craniovertebral junction know that this concept has completely revolutionized craniovertebral junction surgery. So open the joint, distract the facet, and reduce the dislocation. So this is a fixed inflection extension. There is no movement. So open the joint, manually distract the facet, and reduce the dislocation. So this is another case, fixed atlantoaxial dislocation. Open the joint, distract the facet, and reduce the dislocation. So this has completely revolutionized craniovertebral junction surgery. This is another case. You see there is no space for the spinal cord in flexion and in extension. Open the joint, distract the facet, and reduce the dislocation. So there is no need for transoral decompression. There is no need for posterior decompression. So my current concept is that decompression is never necessary from front or from behind. It is you have to craniovertebral junction realignment. You see there is massive dislocation here in flexion and extension. The facets are in malalignment. You can do craniovertebral junction realignment, only atlantoaxial stabilization, even when there is assimilation of atlas. No occipital bone fixation ever. Bifid is another very complex situation. Bifid is a natural reparative and natural protective mechanism of atlantoaxial instability. When you do flexion, the bifid opens. When you do extension, bifid closes. So this was the concept that bifid is a protective mechanism. Unlike spina bifida of the lumbar spine, this is a protection. So when you do flexion, the facets go laterally. So there is a mobility, and facets go laterally, and there is a realignment of these facets, and the shape also of the facets can change. So this is a case of trauma. When there is a fracture of the arch of atlas, the facets go laterally. So this is a lateral dislocation, and this patient needs open the joint, reduce the dislocation. So manual realignment of traumatic dislocation like this. So when there is a facetal malalignment, there is no need for decompression. What you have to do is you have to learn the art of opening the facetal articulation, manipulate the facet, and realign the craniovertebral junction. So that is the treatment. Rotatory dislocation, nobody in the world knew how to treat rotatory dislocation. So we introduced this technique to open the joint, manually manipulate the facet, and realign and then fix. So, and you can produce beautiful new neck in the evening of operation. And we have got several cases like this where we have changed the neck from abnormal to normal. And you see, this is the neck and this is the post-operative. Open the joint, manually manipulate the facet, and fix the atlantoaxial joint, and you can reduce the joint in the immediate post-operative period. You see this guy, he looks very handsome. After the operation, he lost his beautiful hair and he gained a new neck. You see there is a rotatory dislocation, and open the joint, manually manipulate the facet, reduce the dislocation, and realign the craniovertebral junction. The other very important issue in craniovertebral junction is basilar invagination. Nobody really understood basilar invagination. This was our article in 1988 where we said basilar invagination, there are two types. In one, odontoid goes up, in the second, tonsil comes down. So the problem in this situation was that the atlantoaxial instability was fixed, and decompression was the treatment. So transoral decompression for group 1 and foramen magnum decompression for group 2 was the treatment that we recommended in 1998. So decompression, anomaly is fixed, decompression is the treatment. This is what we understood and we described. We also described that in this situation, in cases of Chiari malformation and basilar invagination, in foramen magnum, there is no need to open the bone and there is no need to open the dura. This is what we describe. We don't do it now, but we describe. So in 2004, our concept changed. Our concept for group 1, we described that this is unstable basilar invagination. For group B, our impression was still that there is a stable atlantoaxial joint in group B. This was my concept. So for group A, we describe open the joint, distract the facet, and do craniovertebral junction realignment. Let me show you some cases. So this is basilar invagination. We have said that this is not fixed. This is unstable craniovertebral junction. So you open the joint, distract the facet, fix the joint, and do craniovertebral junction realignment. So instability is the problem and stabilization is the treatment. So this is another case of basilar invagination. Open the joint, distract the facet, and reduce and realign the craniovertebral junction. So there is no need for decompression in these cases, neither anterior decompression nor posterior decompression. So we have got several cases now, such basilar invagination and craniovertebral junction realignment. So we removed the word decompression from this operation. So this was my first case in the year 2000. So 20 years ago, I did this case. You see there is basilar invagination here. There is huge hump of the brainstem. Open the joint, distract the facets, and reduce the craniovertebral junction and basilar invagination. More important is that basilar invagination is an unstable situation and stabilization is the treatment. This is another case of basilar invagination. You see the facets are in malalignment. You reduce the craniovertebral junction and you give new life. Most important is that you give new life. You give absolutely, the person improves in the hands, in the legs, in the pain, and in the breathing, and all the symptoms are gone in the immediate post-operative period. So the concept is, even when there is assimilation of atlas, you have to do atlantoaxial fixation. The concept is that there is no need to do any kind of decompression. And the concept is that the occipital fixation is not necessary. So this is basilar invagination. You see the facets are in very tremendously malaligned situation. This is preoperative and postoperative in alignment, and there is atlantoaxial fixation. There is no decompression. This is another case. You see inflection, it goes up. In extension, it comes down. So there is a vertical instability. And you see post-operative, there is complete reduction and realignment of the craniovertebral junction. This is another case of basilar invagination. You see the facets and you see the craniovertebral junction realignment. Another beautiful case, you see inflection, extension. The vertebral arteries are in difficult situation. You have to understand the vertebral artery. Even when there is assimilation of atlas, you have to do. There is no question. You cannot do occipital fixation. It is a suboptimal kind of fixation. These are unstable situations, and you need to stabilize these patients. This is huge basilar invagination. And you see the facets are in difficult situation, but you can do craniovertebral junction realignment. You see, even if it is incomplete, doesn't matter. Instability is the issue and stabilization is the treatment. So we completely demolished. Transoral surgery is now completely removed from my department for more than 20 years or more, even more. So transoral decompression is never required in craniovertebral junction instability. Now I want to take you to another beautiful concept. There is acute atlantoaxial instability and there is a chronic atlantoaxial instability. Chronic means for over 20 years, over 30 years. And when there is a chronic atlantoaxial instability, there are several natural reparative gains. Several things happen which are natural and protective. Like short neck, torticollis, clipal file abnormality, bone fusion, platybasia, C1 assimilation, C2-3 fusion, and several other problems. You do atlantoaxial fixation and you reverse. You see, these are long-standing musculoskeletal changes due to chronic atlantoaxial instability. So this torticollis is not primary. It is not congenital. It is due to atlantoaxial instability. Clipal file abnormality is not primary. It is due to atlantoaxial instability. C1 assimilation is not primary. It is due to atlantoaxial instability. Platybasia, basilar invagination are not primary. They are due to atlantoaxial instability. You do atlantoaxial stabilization, you can return the neck in the evening of operation. Not only return of torticollis, but even the short neck can become long neck. So that is the beauty. You see, this is the torticollis and this is immediate post-operative. In the immediate post-operative period, there is long neck and the torticollis has gone. So torticollis, short neck, and a whole range of musculoskeletal abnormalities, which we call abnormalities. They are not abnormal, they are protective. So these, you can have a return of neck. You see this turn neck and you can have a straight neck. So all these problems are due to atlantoaxial instability. You stabilize the atlantoaxial joint and these things will return back to normal. So this is another beautiful smile. Not only the neck and the torticollis, but the hands become normal, the legs become normal, the pain goes, and the person starts living a normal, beautiful life. So this is torticollis and this is return to normal. This is basilar invagination. This is reduction and fixation. So there are several cases with me now where there are return of the neck becomes long, neck becomes straight. The issue is you have to learn atlantoaxial stabilization. Bone fusions, several bone fusions are not primary. They are secondary to one problem, and that problem is atlantoaxial instability. You do atlantoaxials when there is cervical fusion. You have to do atlantoaxial stabilization. You see, there is multi-level cervical fusion. There is no compression at the atlantoaxial joint. But you do flexion extension, you see an unstable atlantoaxial joint. Bone fusions are secondary, and bone fusions are protective. You do atlantoaxial stabilization in this young girl, and you give absolutely new life. This patient was a very high-profile politician's daughter. She was not even breathing properly. In the evening of operation, she could sing and she could have a wonderful breathing, which she never had in her life. Bifid, as I mentioned to you, it is a protective. You do flexion extension. So this bifid is also a natural protective maneuvering. So you see, when there is bifid, there is atlantoaxial instability. When there is spina bifida, when there is spinal fusion, it is atlantoaxial instability. When there is assimilation of atlas, there is atlantoaxial instability. When there is platybasia or basilar invagination, there is atlantoaxial instability, and you have to do atlantoaxial stabilization. So these bone fusions, bifid atlas, are all manifestations of atlantoaxial instability, and you have to do atlantoaxial stabilization. I recently published my series of 190 cases, and 100% recovery. All patients in my series have recovered. Os odontoideum is a secondary manifestation of atlantoaxial instability. Os odontoideum is a protective phenomena. You know, this entity is not very well understood. When there is os odontoideum like this, many people do occipitoaxial fixation. Many people do transoral decompression. Absolutely wrong. You have to do atlantoaxial fixation. Open the joint, reduce the dislocation, and fix the joint. That is the treatment. Decompression is not the treatment. So I have got several cases of os odontoideum, and there is what you have to do: open the joint, remove the cartilage, do atlantoaxial fixation. That is the treatment. So I talked about musculoskeletal abnormality. Now I'm saying that in chronic atlantoaxial instability, syringomyelia, Chiari malformation are secondary neural transformation or neural alteration. They are not primary, they are secondary to atlantoaxial instability. Syringomyelia, you put a tube in the syringomyelia, that is a negative operation. Do not treat syringomyelia, because syringomyelia is helpful and not harmful. It indicates the presence of atlantoaxial instability. Now I will discuss the issue of central or axial atlantoaxial instability. This is a new entity, and believe me, my dear friends, this has the potential of completely revolutionizing the field of craniovertebral junction and cervical spine. So you remember what I'm saying. Complete revolution in the cervical spine. So I wish to introduce to you the issue of central or axial atlantoaxial instability. So we had talked that basilar invagination is due to facetal instability like this, facetal listhesis, like lumbosacral listhesis. So this is the case. This is the listhesis of C1 over C2, like lumbosacral listhesis. So this is an unstable situation, and you need to stabilize. You don't need to do decompression. You need to do stabilization. So this is another case where there is a C1 over C2 listhesis, and there is basilar invagination. You have to do C1, C2 fixation because this is an unstable situation. Now I want to show you, like this we know, C1 over C2 listhesis. There is increased atlantodental interval, and this is the only parameter to show unstable atlantoaxial joint and compression of the neural structures. Now you see this one. This is type 1. This is type 2. Facet of atlas is in front of facet of axis. facet of atlas is behind the facet of axis. You see here, front, behind. So this kind of basilar invagination, there is no unstable atlantoaxial joint here, no atlantodental interval disturbance, but there is type 2 unstable spine, and this patient needs stabilization. This patient does not need decompression. So this is my new concept. Even when there is no atlantodental interval disturbance, the presence of Chiari, presence of syringomyelia are indicators of unstable atlantoaxial joint, assimilation of atlas, and you need to do atlantoaxial stabilization. You see syringomyelia has disappeared and there is need for atlantoaxial stabilization. So we must see the facetal malalignment and we must do atlantoaxial stabilization. So this basilar invagination, the whole world will do foramen magnum decompression. So I am saying no, this is an unstable facetal type 2 instability, and you need to do atlantoaxial stabilization. And believe me, my dear friends, I know many of the friends in the audience are young neurosurgeons. You believe me what I'm saying. You give new life, and absolutely new life if you do fixation. And if you do decompression, you are wasting your time. It is a non-clinical operation. So this is a basilar invagination. You see there is no atlantodental interval disturbance. There is no compression. So don't do decompression. It's a negative operation. You see the facetal malalignment. You have to do atlantoaxial stabilization and you give absolutely a new person. You see there is atlantodental interval disturbance a little bit. There is huge basilar invagination. There is no need for foramen magnum decompression. Posterior fossa is not tight. You see there is so much CSF spaces. And you have to do, you see this is syringomyelia. I do atlantoaxial stabilization and you see the syringomyelia has disappeared. There is no anterior decompression. There is no posterior decompression. So decompression is not the answer. There is no facetal malalignment. There is no atlantodental interval disturbance. The presence of basilar invagination, presence of Chiari are indicators of unstable atlantoaxial joint, and atlantoaxial stabilization is the treatment. You see there is basilar invagination, syringomyelia, no atlantodental interval disturbance, no posterior fossa tight, syringomyelia. There is facetal instability. There is assimilation of atlas. Do not do occipital fixation. Do atlantoaxial fixation and you give new life to this patient. There is another case. You see Chiari malformation, syringomyelia, no atlantodental interval disturbance, no facetal malalignment. This is an unstable atlantoaxial joint. So basilar invagination is always associated with an unstable atlantoaxial joint. Whether it is group A, whether it is group B, there is need for atlantoaxial stabilization. Basilar invagination, syringomyelia, and Chiari malformation are related to atlantoaxial instability. Foramen magnum decompression of any kind is a negative, is not a good operation, all right. I'm not saying it is a good operation. I'm saying it is a bad operation. It is a negative operation. So atlantoaxial instability is the cause of Chiari malformation and atlantoaxial fixation is the treatment. You see there is Chiari malformation and there is syringomyelia. You see the facetal malalignment. Any kind of decompression can be a bad operation. Do atlantoaxial fixation and you reduce the syrinx. So I have got several cases now. There is facetal malalignment. There is no atlantodental interval disturbance. I do atlantoaxial stabilization. You see the syringomyelia has reduced. Whether the syringomyelia reduce or not, that is not the issue. The patient will improve remarkably in clinical manifestation. Chiari malformation, no facetal malalignment, no atlantodental interval, atlantoaxial fixation is the treatment. You see there is no atlantodental interval disturbance. There is no facetal malalignment. There is big basilar invagination, assimilation of atlas. There is atlantoaxial fixation. You see the syringomyelia has disappeared. The tonsil has regressed. more important is the patient recovers remarkably. Remarkable is the key word. You see syringomyelia, Chiari malformation, no atlantodental interval disturbance, no facetal malalignment. You do atlantoaxial fixation and you do give a new human life in the evening of operation. So there are Chiari malformation was, many people asked me about this, letters to editors and things like that. Just see few cases, there is no problem. There is a problem here. The syringomyelia has recovered. There is another case of Chiari and syrinx and no facetal malalignment. And there is a spacer. I don't put spacers often. No problem, no problem. Chiari malformation, no tight posterior fossa, atlantoaxial fixation is the treatment. You see, sometimes the syringomyelia can recover in the immediate post-operative period. This is pre-operative, this is immediate post-operative, and this is after 6 months. So now I have to say that after 1 year, all the patient, 100%, the syringomyelia will recover. This is pre-operative and post-operative imaging. This is no problem. There is some unstable and the syringomyelia recovers. This is pre-operative. You see there is basilar invagination and there is syringomyelia, Chiari malformation, syringomyelia reduced, atlantoaxial fixation, no decompression. As you can understand, many people asked me various questions and it was a difficult time for me to answer, but the concept is now clear and the concept is absolutely clear. So when there is no craniovertebral junction bone abnormality, no basilar invagination, even then there is the presence of Chiari and syrinx can indicate the presence of an unstable spine and you need to do atlantoaxial stabilization. The syringomyelia will recover. There is preoperative, see the atlantoaxial joint, see the odontoid process, atlantoaxial fixation. Syringomyelia, Chiari malformation, see the atlantoaxial joint, see the facetal alignment, see the syringomyelia has gone, atlantoaxial fixation, no decompression of any kind. This is another case, syringomyelia, Chiari, no problem, no problem. This is another case of, see the facetal malalignment in this case, and this is the tonsil has regressed remarkably. You see the tonsil has regressed. So syringomyelia, the syringomyelia has regressed, atlantoaxial joint instability, atlantoaxial joint stabilization, preoperative, postoperative, atlantoaxial stabilization. Another case, you see huge syringomyelia, Chiari basilar invagination. So whether there is basilar invagination or not, whether there is any other kind, whether there is syringomyelia or not, whether there is bone fusion or not, these are all complex related to chronic atlantoaxial instability and you need to do stabilization. Syringomyelia, no problem here, no problem here, atlantoaxial stabilization, syringomyelia gone. Whether syringomyelia goes or not, that is not the issue. The patient has to recover. And I have to say that patient will not just recover, patient will be cured. So just one case I am going to show you. This is immediate postoperative, immediate. You see the walking has little bit improved, not little bit. This patient is cured and this patient is cured forever. This patient came with 6 nerve weakness here. You see there is Chiari and there is facetal malalignment and the 6th nerve recovered immediate after surgery. So these are complex issues. The fixation is not easy, but if you can do, you can give new life. So one patient, this is one patient I will show you, has been treated several times, 13 operations for foramen magnum decompression, shunt, and ventriculoperitoneal shunts and things like that. And then he comes to me and then I do atlantoaxial fixation and he gets a new life. You see there is a shunt here, foramen magnum decompression, there is syringomyelia, multiple operation, and this patient also gets a new life. So what I will do is I will now like to stop and I will like to have questions and then I will go further if you will ask me. So Mehmet.
Hi Atul.
Yeah.
very precious talk, really. We enjoyed it a lot.
Thank you very much.
We reached more than 200 participants. Thank you for your name. It happened. I will start by in the row asking the questions. One thing is that which technique provides more stable joint, using superior or inferior facet of C2?
No, inferior facet should not be used. Inferior facet is a inferior technique. Superior facet is the best. I am saying only when there is a very high riding vertebral artery and you are not able to put a screw. Suppose you are not able to put the screw in C2 because of the vertebral artery. Then in those situations, you can use inferior facet in a desperate, as a salvage, not as a regular.
Right. If you have moved the vertebral artery and you place a screw afterwards,
yeah,
you place anything to avoid screw arterial fistulization?
Was that? I couldn't understand, Mehmet.
Yeah, I mean, if the screw is touching the vertebral artery, do you scare of that?
No, I will put some Surgicel or gel foam or some kind of material there, but it is not really necessary, not necessary.
Okay. The usual question that there is a lot of bleeding from venous structures. How do you deal with them?
See, the problem is there can be venous bleeding. It is not easy. This operation is not easy. This operation is dangerous. This operation can lead to huge blood loss. But if you can do it, you give new life. So if there is venous bleeding, you have to handle the venous bleeding. If there is arteries in between, you have to handle the artery. So the question is whether you can do it. If there is venous bleeding, you cannot say in neurosurgery, whatever is difficult, we have to handle difficulty. Basically, we have to do the treatment, and we have to do the treatment by fixation. Atlantoaxial instability is a very common thing. Atlantoaxial instability is also associated with cervical spondylosis. It is also associated it can be associated with several other cervical problems, which I am going to talk to you after, if you give me time after this. So atlantoaxial instability is common, and atlantoaxial stabilization is a very important spinal surgical technique and procedure, and we have to learn it. If it is venous bleeding, we have to control with gel foam, we have to control with Surgicel, and we have to do a quick operation. I finished this operation in half an hour or 45 minutes. Because if you delay the operation for 5 hours or 10 hours, then the bleeding will be too much. So you have to rapidly do the operation. You have to do subperiosteal dissection. You have to go on the lamina and on the pedicle and expose the joint early in the operation. So this operation, particularly when there is syringomyelia, when there is basilar invagination, the operation can be very difficult.
Okay.
It is not easy.
Okay. Atul, do you use skull traction to open the C1-C2 joint?
No, I use always skull traction, always. But that is just to keep the head stable during operation. Head should not move during operation. The eye should be protected. The head is high. The head is floating. So my traction is always there, but it is not to open the joint. I open it manually. That traction is not to open the joint, but to keep the joint stable, keep the head high, and reduce the venous pressure, venous congestion in the area.
Okay. Another question there, do you perform routinely angiography before surgery to see the vertebral artery?
No need to do angiography. We do CT scan, we do MRI, we see the vertebral artery loop. In complex situations, I use 3D models, which I showed you, 3D models. So angiography per se is not, but CT angiography, MR angiography is helpful in this situation.
Okay. One question from Dr. Deepak Singh, I think Indian. Can you explain the pathophysiology of syrinx formation in view of facetal misalignment only?
See, this is a very complex subject. You know, I have written about it, that Chiari malformation, I don't call it Chiari malformation, I call it Chiari formation, because it is a protective phenomena. Even syringomyelia, this is, I call it protective. This is all natural protective maneuvering in cases of chronic atlantoaxial instability. So that is the, natural protection, natural self-neural destruction to protect the human being. So it is a, if you will like to read my articles, I have mentioned on several occasions about syringomyelia and its pathogenesis.
Okay. Do you use bone graft always in atlantoaxial stabilization?
Always, always.
Where do you place them?
100%. I place them into the C1-C2 articulation. Mehmet, you think I should show one case? If you allow me, I will show you one case rather than, these questions can be a little bit, I can show you one case. So that may be a good thing for the people who are watching. You want me to show a case?
Atul, there is actually, they haven't asked here, but at the beginning you were placing a spacer there. Now you are placing just a bone graft.
Yeah, I described this. I used to place spacer on a regular basis earlier, but I have now changed because my concept is that bone fusion, stabilization is the key. And you put more bone graft in the joint, it becomes more, the fusion becomes more. I use spacers little bit less commonly in cases of very severe basilar invagination, where I need to distract and where I'm not able to do C1-C2 proper stabilization with screws. So I use it as a stabilizer rather than as a, distractor.
Okay. A Turkish participant, Dr. Ayhan Kanat, is asking the rate and size reduction of syrinx. Have you seen recurrence of syrinx size after?
No, this is a very important question. Let me answer this properly. See, syrinx will regress 100% of time in about 1 year's time. In about 15% of patients, the syrinx size will regress. After 48 hours, you do MRI, syrinx size will regress. My answer is that reduction of syrinx is a good issue, but it is not a very important thing. What is important is that the patient should recover, and patient should recover remarkably. Little bit, here and there is not. I am saying, and you listen very properly because, I see more than 200 people watching and many of you are young. I am saying, and you keep it very clear in your mind, I am saying the person will get new life in the evening of operation. New life means the breathing improves, the voice improves, the person can sleep properly, sleep apneas go, tingling in the hands and power in the fingers improve in the evening of operation. The pain in the shoulder, the myelopathic pain in syringomyelia and Chiari, immediate in the evening of operation, finished. So this is an important operation which we must learn. And I have got several people in the audience I see are my students. From Turkey also, I see some people who have been trained with me here in Mumbai. Some Turkish students I can see. And I will like to invite you, if you are having, some confusion and some doubts, I wish that you can come and spend some time in my department. We are doing, even during Corona times, many of these cases, new life in the evening of operation.
Yeah, okay. Actually, there are two questions, one from Dr. Yasin, one from Dr. Vehbi. Both are similar questions. They want to stress or want you to stress it, that the posterior fossa decompression androplasty is working? It is easy and less risky. Must we leave this technique and change our direction to C1-C2 fusion?
See, you know what, if I had shown one paper of mine where in the year 1998, 22 years ago, I described foramen magnum decompression. For the first time in the literature, I said that the posterior fossa is tight and you do bone decompression. I said first time in the literature. In 1998, you read my paper, I have put in my slides. As I understood this subject more, there is no question, there is no doubt, and you please do not keep this doubt in your mind that foramen magnum decompression will cure the person. Foramen magnum decompression, now you will ask me this question, many people ask me, like you do foramen magnum decompression, the patient improves, many patients improve. Then how the patient can improve after foramen magnum decompression? My answer is when you do take incision in the neck, you do neck dissection, there is pain in the neck and the muscles under spasm for 2-3 months, and there can be relief of some symptoms for 2-3 months. But you be genuinely ask your own patient after 6 months, how many patients of yours have improved after 6 months? And now I have got several patients from all over the world. I am getting patients where the foramen magnum decompression has been done and the patient has marginally improved, a little bit here and there, and the symptoms has recurred. So at that time, you have to learn to do C1-C2 fixation. When you have done foramen magnum decompression, the C1-C2 becomes more difficult. But you do fixation, give new life.
Okay. The two questions about the position of the patient. Do you give a special position to the head before starting surgery?
Yes, I do about 35-degree head high position, 35, under traction. 35-degree head high position under traction, it gives me floating head position. The headrest is just kept for safety purpose. And if I will like to show you the position also in the technique which I will show you now.
Okay.
In the whole operative procedure, about 15 minutes.
Do you use Mayfield head clamps?
No, I use Gardner-Wells traction, Gardner-Wells.
Have you done any vertebral artery injury during C1-C2 fixation?
Many times. You see, I have done this operation more than 2,700 times about. And I have damaged vertebral artery on several occasions. And that is the danger of this operation. You can damage the vertebral artery. But then you have to, when you are damaged, you cannot run away. You have to control. So when you have damaged the vertebral artery, when you are putting C2 screw, and suddenly the blood comes from the C2, that is the time you have damaged the vertebral artery. So what you have to do is at that time, you put a large C2 screw and immediately the bleeding will stop. You have to put the screw like that. You cannot look for the bleeding. You have to complete the operation. That is one place. Second place is if the artery is damaged lateral to the lateral mass, then you have to try to control the artery and do suturing. It is possible, but it is difficult but possible. You try to suture the vessel. If you are not able to suture the vessel, it is better to quickly sacrifice the vertebral artery. More often than not, nothing will happen. Something can happen. It is a danger. I have to also tell the young people in the audience, I have damaged the vertebral artery. I have damaged the vertebral artery on both sides also on some occasion without any problem. It is a big issue. You can kill the person. Patient can die. But it is not such an issue that you should be so much scared. Sacrifice of one vertebral artery is quite safe. You should not do, but it is quite safe.
Okay. Some friends are asking to show you the video of surgery.
Yes.
And one question is unique. Actually, do you apply any any traction on the screws to place
No.
the...
No, I distract the facets. What I do is I open the
Distract
facet.
facet, not with the screws.
No, not with the screws. Distract the facet and push the bone graft in the facet joint. That is my technique. Okay, let me show you the video of one case, okay?
Okay.
Wait. Another thing, I will like to just show you a few slides. Like there is syringomyelia here. There is no Chiari malformation. Syringomyelia itself is a cause of atlantoaxial instability. If there is only assimilation of atlas, that is unstable atlantoaxial joint. Only fusion, unstable. Only platybasia, unstable. So you must remember this. See, there is kyphoscoliosis here. That is also a manifestation of atlantoaxial instability. And you do atlantoaxial stabilization, the kyphoscoliosis will return in the quick. This is after 3 months of operation, the kyphoscoliosis has returned, has recovered. And the transcranial motor evoked potentials can recover during operation. You see, recovery during operation. So this is a very, very important, you must not neglect this. I'm telling you, you can give beautiful smile to these children and beautiful smile to the doctor in a very quick time. And you must, those who are afraid of atlantoaxial stabilization, I must tell you that foramen magnum decompression surgery can become historical. Don't be after that operation. So now let me show you the technique. So this is the technique. MRI scan. Wait, just a minute. Let me stop the voice here so I can talk myself. So here I'm putting traction. You see, this is, I'm holding the head. You see, during the time I'm holding the head, this is Gardner-Wells traction. And this can be done in 2 minutes, not 4 minutes, only 2 minutes. You put traction and you see now I'm turning the patient and holding the head. The traction is also on. It is very important that you hold the traction in your hand. You see, this is, I am standing here and the traction I am continuously applying. So whilst turning the patient, the traction has to be very carefully, you have to hold the traction. And this is the head high. You see, it is, the head is just touching. It is head high position and under traction. I prepare the iliac crest. I always take the bone from the iliac crest. Now, some of you have been to me in the audience, I know, and some of you have spent a good number of months with me. I know, though I don't want to name them because it may not be correct. But in my technique, there is no coagulation. I never use bipolar in my, I've never used bipolar, unipolar. Monopolar, I've never used. Bipolar also very rarely. So this is the C2 spinous process. I'm sharply cutting. And this is almost an unedited tape. You see, there is no, on the spinous, on the lamina. And then I'm cutting in the region of the lateral gutter. You must remember that this is not an edited tape. This is almost completely an unedited tape. And you see this operation, I'm dissecting in the region of pedicle. This is the spinous process. This is the lamina. This is the pedicle. See, I am not sure if you can see properly. This is the C2 ganglion, which I am now dissecting. Now it is under magnification. You can see better. There can be furious venous bleeding, as Mehmet was saying. This is the C2 ganglion. I'm dissecting. This is the lamina. I'm dissecting the ganglion. Nowadays, I don't cut the ganglion in most cases. You see here, this is the pedicle. I'm going right. I'm opening the joint. I will open the joint here. This is the C2 ganglion. You see, it is quite a large ganglion. You see, I normally, you see, do not cut, but here I am cutting just, you know, this is a very old video which I had prepared. So I have cut the C2 ganglion. I must say I don't cut the C2 ganglion now. And you see here, I have opened the joint, exposed the joint. And I am cutting sharply over the C1 facet. This venous bleeding, if it is occurring, you have to stop by Surgicel or you have to pack that area. But you cannot, you see, I have opened the joint, I have put an osteotome there and I have distracted the facet. You see that? And then I am exposing the C1 facet a little bit more. I must say the young people in the audience have to learn this technique. There is no escape from this. This is the C1 facet. And I have to also say that, you know, you can run away from this technique and do occipital fixation, which is not a good way to treat this, not a good way. I have told you, I describe occipital screws. I have described my own technique of occipital cervical fixation, but no, not more. So this is the C1 facet. This is the C1-C2 articulation. I'm just controlling the bleeding with Surgicel or with gel foam. You see, this is C1-C2 articulation, which is quite widely open. The osteotome is in place. Now I will prepare. You see this bone graft I am putting in the joint. You see that? You see bone graft in the facetal articulation. And I put quite a bit of bone. You see quite a bit of bone. This bone putting is absolutely necessary or mandatory. You cannot say, I have done fixation, I have not put bone in the joint. If you have not put bone in the joint, your technique can fail, I must tell you. Your operation can fail. So you have to put bone graft in the joint. So now what I'm doing is, I'm preparing for instrumentation. You see, I am drilling in the region of pars, lateral to the lamina, lateral to the lamina. I'm drilling for my instrumentation. You will see now, very soon. This is the C1 facet. This is the articulation with bone graft now. Now you see my instrumentation will be there now. This is the C1 facet. I have introduced bone graft in the joint already. See, I'm making a hole in the facet of C1. This is the hole in the facet of C1. You can use polyaxial screws or polyaxial rod and screws, but I like this, my plate and screws, which are very, very strong and very much focused on the facets. So I have put the C1 screw and I have put a plate. You see, I had drilled this area so that I can move my plate on that area. I am now placing the plate in the best position to put the screw in the C2 now. See, now my C2 screw will be very high and very medial. So that is my trick to avoid vertebral artery. And if it is vertebral artery, you have to know before operation how much medially it is going. So here, this area I have drilled already, and you see my screw is very medial and very superior and directly in the pedicle. You see here, this is the direction of my C2 screw. Medial and superior. You see, this is the direction of my C2 screw. Then I turn the plate and then introduce the C2 screw. Which is then tightened. I must say that in this operation, you cannot accept any kind of compromise. If your screw is not having the grip, you have to change it. If your facet C1 screw is not strong, you cannot accept compromise because this operation gives new life. This operation is game changer for the person. Suboptimal, you say, oh, it is bleeding, so I don't put bone in the joint. That is a suboptimal fixation. You have to do bone fixation. You have to achieve arthrodesis. That can be achieved only if you have put bone graft in the joint. And then you do stabilization with this. There is another step which I will tell you very soon. What is very important in this technique.
I understand you don't look at the C-arm, fluoro. Do you?
Mehmet, you said something?
Yeah. Do you look at the C-arm?
No, I don't look at. No, I don't look at the C-arm. No, I don't look at the C-arm. I have actually. Let me continue. Okay. Wait. Now I am doing on the other side. See, this is some This is on the other side. Mehmet, the other thing which I want to tell the young people and also to the senior people, that bleeding, we have to learn to handle the bleeding. We cannot say that we cannot do because bleeding is going on.
The screw diameters are 3.5.
No, these are 2.8 to 3 millimeters diameter.
YouTube पे कभी अजमेर पे वो देख है ना अजमेर पे नहीं ये अजमेर के निजामुद्दीन औली उसी चेहरे के उसी उन्होंने
Now, another beautiful thing which I'm going to show, Mehmet, now you just see after the screw, after the instrumentation, one thing I am going to show you now, which is also very critically important, very critically important. You see, you have tightened the screw, you have completed the fixation. You have put bone graft in the joint. Now, you see this. See, I am cutting all the muscles attached to this C1 and C2. All the muscles attached to the C2 spinous process. This is very critical step, Mehmet, very critical step. Then I drill. You see how I am drilling the spinous process?
You also cut the C2, C3 muscles.
All the muscles attached to the C2 spinous process are cut sharply. This is very important. Now you see another thing. See how much bone graft I am putting here. You see here? This is also very, very important that you put bone graft here after making the area host bone
From iliac crest?
from iliac crest, and always from iliac crest. So what I'll do, Mehmet, is now I will wait for some more questions and then I will give another 10 minutes of lecture. Okay?
Okay, this is fine.
So I will wait for the questions, then 10 minutes of quick lecture I will like to give. Okay?
Yeah. The one question is that do you ever use allograft?
Never, never, never.
Never
Never.
use.
Never. Always from iliac crest. Never from the rib. I used to use from the rib sometimes earlier, but it is a very it is not a good bone graft.
What is the youngest patient you operated?
I have shown that picture. 6 months old child was my youngest. I have done many infants below 1 year. I have done at least 7 or 8 children below 1 year.
In that instance, the screwing, is it hard or okay?
No. You see, in children, in infants, the facets are strong. The arch of atlas may be bifid or maybe cartilaginous, but the facets are strong. And you can do C1, C2 facetal fixation. You cannot do midline fixation in those cases.
Do you change your screw diameter?
Yeah. In children, in infants, of course, the screw diameter becomes 2.2, 2.4, like that, depending on the age.
One question, do you use microscope in all procedures?
Always, always microscope. This operation is very difficult without microscope.
Do you use any brace or something after surgery? Any collar?
Always for 3 months, 3 months collar. And all neck activities are, limited or stopped.
3 months.
3 months. Actually, 2 months is good enough. Actually, you know what? There was one patient I had re-explored in some other unit of some other doctor, and he had put bone graft, and I had re-explored in about 10 days. And in 10 days, there was bone fusion. So bone fusion can be very quick if you have prepared the bone, the host bone properly. In 10 days, the bone fusion can start.
Okay. We understood that the screw diameter you use are 2.8 to 3 millimeters.
Yes.
What about the length of the screws?
Length is 26 millimeter, 24 millimeter, 26 millimeter is my optimum length in
Okay.
adults. In adults.
Okay. I think you answered this, but I am asking again, what is the reason to cut the muscles from C1 and C2 to place grafts, isn't it?
Yes, I have told you, you know what? This is absolutely important to cut the muscles because C2 spinous process is the strongest spinous process of the whole body. There are very strong muscles attached there. So you put an implant and you do not cut the muscles, these muscles will go on pulling your spinous process and will break any kind of metal implant. You have to cut and you have to bone fuse. To achieve arthrodesis, you have to sacrifice movements. You know, unless you cut the muscles, you do not sacrifice movements. Unless you sacrifice the movement, arthrodesis will not be achieved. So to achieve bone fusion, muscles have to be cut, period.
Okay. Do we also drill posterior surface of C1 arch?
It is, you know, C1 arch, there are not many muscles attached. C1 arch is quite smooth. Yeah. But you cut, if you can drill, it is better for bone fusion. I drill the C1 arch whenever it is easily possible. Sometimes it is assimilated. Then you have to drill the occipital bone.
I will answer that question. Do you mobilize the patient next day? Yes.
Yes, yes. Next day, mobilize.
Okay. Thank you. These are all questions. And we can take you for the next presentation.
Okay. Now I want to discuss about craniovertebral junction instability and degenerative arthritis. You see, craniovertebral junction instability. Whenever we talk of degenerative spine, we talk of C5, C6, we talk of C4, 5, we talk of C2, rarely about C2, 3, but we never talk of craniovertebral junction. I have found that atlantoaxial joint is the most mobile joint, and atlantoaxial degeneration is the commonest form of degeneration. So this is the article I wrote in 2010. About 108 cases we had discussed about degeneration of the C1, C2 region. Excuse me, sorry. So you see, when there is atlantoaxial instability, there can be osteophyte formation. There can be reduction in the joint space. There can be buckling of the posterior longitudinal ligament. So atlantoaxial instability is manifested by reduction in the joint space, osteophyte formation, and buckling of the posterior longitudinal ligament, and osteophyte formation. So this is not os odontoideum. This is osteophyte formation in the apical ligament. So when you see osteophyte formation, when you see abnormal bone formation, this is a manifestation of atlantoaxial instability, and you need to do stabilization. You do not need decompression. So this kind of osteophyte formation, you see apical ligament, there is atlantoaxial instability. This is an unstable atlantoaxial joint. You need to do stabilization. So this is apical ligament. This bone formation is a secondary to atlantoaxial instability. This bone formation in the apical ligament is due to unstable atlantoaxial joint, and also you see posterior longitudinal ligament, OPLL formation. So my concept is that osteophyte formation, OPLL formation, is a manifestation of an unstable spine. I am repeating this for the sake of young people. You please carefully listen. What I'm saying is osteophyte formation and posterior longitudinal ligament ossifications are manifestations of an unstable spine. Retroodontoid, you see this ossification that you are seeing, retroodontoid ossification is a manifestation of atlantoaxial instability. there is no need to remove this. This is not primary, this is secondary. So retroodontoid ossification or pseudotumor is a manifestation of an unstable atlantoaxial joint, and you need to do stabilization. We mentioned this first in the year 2000. So this is in the 2004, I published this first case report where we said that retroodontoid mass or osteophyte, which I call it osteophyte, is not a primary process. It is secondary to atlantoaxial instability, and you do not need to remove this. You need to stabilize the joint. So there is a retroodontoid cyst formation. This cyst is not a primary phenomena. It is secondary to an unstable atlantoaxial joint. You stabilize the joint, this cyst will disappear eventually. May disappear in the post-operative period or disappear after 3 months. So what we said is that there can be a possibility of immediate post-operative disappearance of retroodontoid pseudotumor. So there is a cyst here. You don't need to remove this cyst. This is unstable atlantoaxial joint. This is secondary. You do atlantoaxial fixation. This can disappear in quick or immediate post-operative period. So you see this, there is atlantoaxial instability. There can be degeneration. So there can be degenerative spine in association in subaxial degeneration. But atlantoaxial degeneration is a very common phenomena. Presence of apical ligament, presence of abnormal ossification are manifestations of an unstable atlantoaxial joint. We also mentioned that in rheumatoid arthritis, this pannus, which we call pannus, you see transoral surgery was done to remove this pannus. So we said that this is buckling of the, Mehmet, you please listen to what I'm saying. We have discussed this in the past. Mehmet and I have discussed this on several occasions. This retroodontoid pannus is secondary to vertical collapse in rheumatoid. And there can be, sorry for that. There can be immediate post-operative regression of the pannus following facetal distraction surgery. So reconstruction, lateral mass reconstruction, the pannus can disappear. So what we have said is that this pannus is not primary. It is secondary to an unstable atlantoaxial joint. So you see there is atlantoaxial instability. You distract the facet, the pannus disappears. So rheumatoid arthritis, there is a vertical collapse. Distraction of facet and reduction is a very beautiful treatment for rheumatoid arthritis. Decompression of any kind is a negative form of treatment. Now I want to introduce a new concept. New concept I want to introduce. The concept is that when there is multi-level cervical spondylotic myelopathy, multi-segmental cervical myelopathy, there is very commonly atlantoaxial instability is associated. Do not ignore it. So multi-segmental cervical spondylotic myelopathy is frequently associated with atlantoaxial instability. The second thing we said was that instability is the nodal point of pathogenesis. Instability, cervical instability or atlantoaxial instability. Instability is the nodal point of pathogenesis of both cervical spondylotic myelopathy and OPLM. Now let me show you. See, there is multi-level spondylotic disease. So what we have said is that multi-level instability is the problem and multi-level stabilization is the treatment. There is no need to do decompression. You see, there is central atlantoaxial instability. There is no compression at the atlantoaxial joint, but there is an atlantoaxial instability. So compression is not the issue. Now, please listen very carefully. Compression is not the problem. Instability is the problem. and atlantoaxial instability and subaxial instabilization is the treatment. There is no need for decompression. So you see there is a cord signal change, there is disc bulge, there is multi-level disc bulge. There is no compression here, no compression. But you see there is a facetal instability, and you need to do atlantoaxial and subaxial stabilization, which is very critical. So cervical spondylosis in patients presenting with severe myelopathy has to be treated by fixation, which includes atlantoaxial stabilization. You see multi-level instability with and very severe myelopathy, no significant compression. We have said that ligamentum flavum bulging, osteophyte formation, reduction in the disc spaces are all due to multi-level spinal degeneration, multi-level vertical spinal instability, and it needs only stabilization. And I use transarticular stabilization, and there is a need to include atlantoaxial joint in the fixation. OPLL, nobody in the world knows the treatment of OPLL, and only decompression is the treatment. So there is OPLL, and only decompression is the treatment, and whole world is doing decompression. I am saying that decompression is a negative operation. This is secondary to spinal degeneration, and atlantoaxial instability is very frequently associated, and only fixation is the treatment. And you see the magic. Multi-levels OPLL, no need for anterior decompression, no need for posterior decompression. It needs multi-segmental stabilization. I had described oblique corpectomy for OPLL for the first time in the literature we had described. You see, I used to do decompression OPLL oblique. So remove this bone and do OPLL removal. Remove this oblique laminectomy I used to do, and we described it for the first time, and these are the pictures from that. So I used this kind of oblique and remove the OPLL. Now I'm saying laminectomy, oblique corpectomy are negative operation. So is atlantoaxial instability the cause of high cervical OPLL? I'm saying yes. I am saying that OPLL is the frequent cause of even low cervical OPLL. So I have written several articles on this. I wish some of you must read these articles, because there is no question in my mind that the pathogenesis of OPLL, pathogenesis of cervical degeneration is now available. We should treat them by only fixation and no decompression. Decompression is a negative treatment, and atlantoaxial joint has to be included in the fixation construct. So this is OPLL, this is unstable. You have to treat by including atlantoaxial joint in the fixation construct. OPLL at multi-level, no atlantodental interval disturbance, no facetal malalignment, but you have to include atlantoaxial joint, and you see the magic. So atlantoaxial and subaxial fixation, can it revolutionize the treatment of cervical myelopathy related to OPLL? Yes, and 100%. So there is also kyphosis like this. Kyphosis. This kyphosis is a manifestation of an unstable spine. You don't do osteotomies and oblique osteotomies and lateral osteotomies and corpectomies. This is a manifestation of unstable cervical spine, and you have to do multi-level stabilization. Hirayama disease, I am not sure many of you know, but Hirayama disease is a common in young people, and it is a manifestation of multi-level spinal degeneration, and is a multi-level spinal instability. You need to do stabilization. If you read the literature, I'm not sure if many of you know this entity. These are not very common, but these are quite disabling, and stabilization is the treatment. Many kinds of decompression have been recommended for this, but they are not such great treatment. So my dear friends, thank you very much, and I hope you have enjoyed this presentation. basilar invagination, syringomalia, Chiari malformation, atlantoaxial instability is the cause. They are natural processes. I like to call Chiari formation, not Chiari malformation. You must know this beautiful entity and treat accordingly. Thank you very much, my dear friends.
Thank you, really, Atul. Great talks and really very challenging points you are raising. There are a few more questions. One is that from the first
Mehmet, I have never seen so many questions on chat box. So there are a huge number of questions.
Yeah. One is that if there is a thoracic syrinx, not cervical syrinx, we see nothing on images. We could not explain the etiology. Does that mean that C1, C2 type 3 instability, or can we say there is another instability at C7, T1?
No. Now listen. See, these are idiopathic syrinx. Sometimes there can be traumatic syrinx. Sometimes there can be infectious syrinx like tuberculosis. There can be syrinx due to various other reasons. So low thoracic is sometimes not associated with craniovertebral, but even thoracic can be associated with cervical C1, C2 instability and should be treated. Yeah. Idiopathic. I have published a paper. You must read this paper.
Yeah, I know. One more thing that you didn't mention in your talk, I think, external syrinx.
External syrinx is another entity which we have described.
One question is that, can there be a dorsal level syrinx with C1, C2 instability?
Yes, that can be. There can be. That is the answer.
And what else? One question is doubting that I cannot imagine how only stabilization can heal all the symptoms in OPLL cases.
See, I know it is difficult for people to accept, but this, I am telling you, a revolution is there, a revolution. You either ignore it or you take it. And if you want to take it, I will, there are some people in the audience from Turkey who have seen all this and they have worked with me. I will recommend that if you have doubts, and you must have doubts because you are treating by decompression all your life. Some of you are very senior. You have been doing decompression for 20 years, 30 years. I'm saying, stop it. Don't do it. I'm saying, whether you want to agree, you don't want to agree, that is on you. You see, this is a new concept. And this is not a new concept. This is a revolution. And take part in this revolution.
Thank you.
I know Mehmet also doesn't agree with many of these concepts. I know it. But Mehmet is my good.
I agree. Yes.
Some of them he agrees. But some of them he will start agreeing very soon. And if he does not agree, I will make him agree. I will bring him to my department and show him for at least 10 days. Several cases, and I will show him the magic.
Okay.
Now I see Abdul Rahim on the panel. Abdul, you are there?
You can unmute Abdul Rahim. Baran, I think.
Abdul, you are there?
Yes, sir. Yes, sir.
Abdul, I want you to say something. Now I want you to say loudly. You are a gentleman. You are very slow, gentle speaking. I want you to speak loudly and tell. What is your experience?
Hocam merhabalar. Sesim geliyor mu?
Geliyor.
Yes, I can hear.
Hocam 2 sefer hocamın yanına gittim. 2014 ve 2019'da.
No, can you speak in English? Can you speak in English?
Okay. I see. One years ago and 6 years ago, I see Goel fellow operation. Really very good operation, and the C1, C2 post-operation one day mobilization and good mobilization hand and voice good voice, and post-operation syringomyeli and basilar invagination. I see post-operation. Yes, operation syringomyeli.
Good.
Have you seen some cases while you were here of OPLL? No. OPLL
Yes, I have seen. I have operation one operation in this city. One operation, but I have one operation.
Kamil, do you want to add something? Kamil Sucu? Yeah, he's not there. Okay.
No. I am here.
Okay.
I am here. I would like to thank Dr. Goel. It was an exceptional lecture. It is a great pleasure for us to see Dr. Goel as a speaker at our conference. His approach, techniques, and explanations are groundbreaking. Thanks a lot again.
Thank you very much. Thank you.
Okay. Baran, do you wish to add anything?
I say for great presentation, thank you. We want to see the operation near Professor in Mumbai. We want to go to Mumbai too, as soon as we can possibly.
I welcome you. I will want you to come. I'm most welcome. I will be very happy to have you come and visit me, and it will be my great pleasure and big honor. And when this corona goes, I will like to come to your beautiful country. I have been to Istanbul. I have been to Istanbul several times, and such a great country, such wonderful people. And you know, I miss Mehmet's boat. He had promised that he will take me in the boat, but he lost his boat in the.
Yes. You should visit me in Izmir. Yeah.
So
thanks a lot, Atul. Yeah, it was a great talk and a very nice, very fruitful discussion. I thank all the participants for their patience and for their participation. I say goodbye.
Thank you and bye-bye.
Bye.